My name is Dr. Franny Coe. I was an older student, went to medical school when I was 39. I turned 40 my first year, and I was a housewife. Got a divorce. Knew I had a brain in my head. I decided I needed to go back to school. Did not really ever want to be a doctor, but I had studied nutrition since my youngest was 6 months old, and prevention. I was really interested in prevention. Got my master's in public health. But I did not want to work in a health department. I did not want to do research. I did not want to sit in a cubicle. It just didn't appeal to me. I loved public health, but that's not where I really wanted to be. I wanted patients. I wanted to be able to teach people on an individual level how to be healthier. And so decided when I was 32, I'm going to go back to school and be a doctor. Everybody flipped out. Oh my gosh, are you crazy? You got 3 little girls at home. I was a homeschool mom, the whole bit. But it really worked out well for me because I was like self-employed. I was studying and they were studying and I was teaching them. I went to a commuter school, so we had quarter system. I could go at night, I could go early in the morning, on the weekends, I could be home with my kids. I got grants and loans. It helped me get by. We were poor as all get out, but I could stay home with my kids and I could get by. So it really worked well for me to go to medical school. And I knew, and they were almost grown when I actually got into medical school because I was almost 40, and so they were teenagers and almost grown, leaving home. So it really worked out well. I knew I wanted to live and practice in a rural area. So I looked all over the north part of the state. I wanted to grow organic food, have a farm, and I wanted to teach people how to eat better, how to grow their own food. So we're developing a teaching farm. We have a food hub in our clinic. So we have vegetables, we sell them cheaply. We have eggs, fresh eggs. We teach everybody how to eat well, and people love it. We try to get people off medicine. Nobody likes to take a lot of medicine. Our older folks don't like taking 10, 20, 15, a whole bunch of pills every day. So we spend a lot of time with them, even before I was DPC. And so I guess I always had a philosophy anyway, of less medicine than more. And solo practice was for me because I practice a lot differently than regular folks. So that's pretty much who I am. I came down to the South when I was 11. This is home to me. I don't remember, we lived a lot of places. I went to a lot of schools. So I just want to live and die here in a little small town in Alabama. And I'd like to continue to educate people, and that's why we started our webpage. And I want to start maybe doing videos and things to help people so they can review stuff that I teach them, and that kind of thing. And I'd love to be able to educate doctors. Educate doctors on how to spend time with their patients, educate doctors on nutrition, teach them, some of the things I know. I've probably read 500 to 1,000 books on nutrition and prevention, and at least I've read lots and lots of books. So I'd love to be able to help folks, with our healthcare system, the whole bit. So that's kind of who I am.
You started your practice when?
I started in medical school 2000, graduated in 2004, residency in Tuscaloosa till 2007. Excuse me. And got out in 2007 and started my practice then. So 11 years.
Then 4 years ago, you heard about DPC. Mm-hmm. And it took you 2 years to get that started up?
Yes. Let's see. So I've been going full-time for 15 months. We started in the summer of 2017. I did it for 6 months, but I only took 30 patients just to try it. I still have my regular clinic, and we hadn't even remodeled or really set up our DPC clinic by itself. But I did 30 DPC people just to try it. And so I did that for about 6 months, and then I went full-time. I said, okay, I already knew in January of last year, that was it. So we remodeled like in November, December, got our rooms and walls and everything, our desks put in and that kind of stuff. And I totally stopped doing the other clinic. And because I was still seeing patients, I was trying to kind of break people in, kind of let them know, and we just kept giving out papers, letting people know what we were doing, why we were doing it. And really, a lot of people thought it was great, and they still do. So it just, it afforded me just, to rest, to have it just looked really good. I was like, I can help a lot of people, but I can also work less and really still enjoy what I do. So to me, it was a no-brainer. I mean, the first minute I heard about it, I was like, whoa.
So it took you 6 months from the time you first heard about it to start?
No, it took me 2 years.
Okay.
And the reason was because I knew what they said was, and I went to a couple of conferences. As soon as he told me about it, like it was November. The next year I went to the first conference. And then 2 years later I went to the second conference. And that's when I said, okay, I'm ready. But there's a lot to it. I have 6,000 patients right now in my clinic. These people need me. I'm in a small town. Doctors are 20, 30 minutes away. And I didn't want to abandon all those people. So I was like, what am I going to do, to have this? I also didn't want to hurt my pharmacist. I thought, I'm taking away some of his business, and we're in a little bitty town, and I didn't want to hurt him. So I just kept thinking about how am I going to do it, how am I going to do it? So I actually talked to somebody to try to buy my clinic. And it was a doctor up in Fort Payne. He was interested. Well, his lawyers told him, she's got to go. I cannot be next door while he's on the other side. And I said, nope, I am not doing it. I am staying here. This is my town. I'm living and dying here, and nobody's getting me out of it. So I said, no, you're not buying my clinic. Well, I had 2 nurse practitioners, and I thought, okay, I'll be a hybrid clinic, and that's what I am. I'm basically a hybrid clinic. Most people do not do it that way. They just are DPC or they're regular. I'm doing both, and there are clinics in the country who are doing both. Right. And I just decided to do it that way. So I've got my nurse practitioners, they're taking care of all our patients. I wrote them a letter way ahead, and I said, this is what I'm thinking about doing. And I really didn't get a lot of negative anything. There were a handful of patients. I literally had a couple people cry. They're like, because they couldn't afford to pay the $50 to see me, and they really didn't want to see anybody else. I had maybe 6 or 8 or 10, really be upset. And I said, but I'm going to be here, and they're like, and I had a couple people leave, and they came back. They came back. So the other thing that happened, after I declared, decided I wanted to do this, and I was actually looking into it, the hospital, the old clinic I had right across the interstate, they put somebody in it because they thought, oh, we're going to get some of her business. It hadn't hurt us a bit. Has not hurt us one iota. So, and I knew it wouldn't. I wasn't worried about it. I'm like, people like us for who we are, and we spend a lot of time with people already, even without DPC. We only put one person on every 30 minutes on our schedules. Most clinics, it's every 10 to 15. So we already see people. We only see 12 a day, 12 to 15. And that's all any of us have ever done. And we still make money. We still make, we make a profit. The girls are happy. And we have a great clinic. So we already spend time with people, and that's why people come to us. Now I can do even more. So several things have happened. I'm able to take off work for a bit. I don't go in till 10. I finish up at 5, and everybody's good with that. I still go to the nursing home on Wednesday. They know I'm not there on Wednesday morning. If I need to take off on Friday, I take off on Friday because I have the other clinic. If somebody has to be touched and seen, they can be seen. I got, one of my nurse practitioners will just look at them and, type a little note, and they're good to go, and they love it. Every time they see one of my DPC's patients, they're like, oh God, I wish I could do this. So the freedom, it's I just don't work as hard. My hours are cut back now. I'm probably still working 50 hours a week because I still have the other clinic. I still have some of the other things I do. The other thing, from the doctor's standpoint, there are some considerations financially. So, because you're starting out with a clinic and you're making $50 a month and you got 10 patients, that's only $500. That's it for that month. So the good thing that I did, because I already had a clinic, we took a quarter, we had space. So I took a quarter of that clinic and started it, and I still had my income from the other clinic. Some people who start out straight from scratch have no other income. So you do have the financial considerations, and what I always tell residents to do is never get into debt. You have a lot more freedom if you don't get into debt. Don't buy lots of big houses and cars and all this stuff right when you go into practice. Stay out of debt. You know, buy as you go, and that's fortunately what I was able to do when I got out of residency. I did not get into debt. So, you know, that's a really big consideration is finances. Like, you know, it's hard to do this if you owe a lot of money everywhere. So because of the way I did it, kept the hybrid clinic, my expenses were super low to start that clinic. Like, you know, I was paying the rent. The whole building is $1,600 rent, so I took a fourth of that. I paid $400. Most people can't get $400 rent, you know, in a building to start a practice. So I really like the way I did it that way. So an older doctor, I think that's the way to go. Keep your clinic, get some nurse practitioners in there, and start your DPC and keep them both going. I mean, you know, that's not ideal for if you just don't want any headache of the other. But I already had all that, and it's you know, I still have a little bit of a headache from Medicare and those insurance companies, but we're doing fine. Some other considerations would be, it depends. And we're in a really small town, 900 people, and so it's been a little over a year, and I have 200 patients. That's really good. And it was 15 months. We hit 200 patients. You're only going to do about 400 to 600. I'm going to stop at 400 because I don't need to do more than that. Most doctors go to about 600.
Because you can physically see that many people.
Yes, you don't want to do more than that. And that was the other reason I didn't want to abandon my patients. You know, we have 5,000, 6,000 patients in our clinic. So, you know, that's another reason I kept that other clinic. So really, you can only see about 600. And that's something that a lot of doctors don't, you know, well, how many can you see? Well, really, you don't want more than 600. First of all, you don't need it financially, because 600 times $50 a month is $360,000 a year, you know. And your expenses are about $120,000 of that, counting your employee and all your supplies and all those types of things. So if you've never heard of DPC and you want to really know what it is, they pay $50 a month, and it can be higher in other places. Like, you're in California, your expenses are a lot higher. You may charge 70, 75, 80, 90, even up to 100. Here, it's so low income, nobody can pay more than about $50 a month, but that's plenty. So, so what do they get for that? So this is what a physician wants to know. What am I giving them for that $50 a month? They can come in multiple times per month. Most people don't. They say that if you have 600 patients, you'll see 1% a day, which is 6 patients a day. Actually, no, wait a minute. 1%, yeah, 1% would be 6 patients a day. I don't think that's true, because I see easily 6 patients. I'm only here from 10 to 5, but I still see more, sometimes 6 to 8 patients a day, and I only have 200. I do tend to, you know, do a lot more for my patients. I see them a lot. I tell them to come back, because I educate so much. But that isn't necessarily so in somebody who practices differently than I do. You may only see 6 patients a day with 600. You are on call for yourself. I actually have done FaceTime and audio calls, which people love. If they don't have to come in, they love it. If I don't have to touch them. Now, sometimes I have to touch them. You got to come in. I need to listen to your lungs. I got to feel your belly. You got belly pain, you're coming in. You know, certain things I got to come in. But they love it if there's nothing physically wrong with them, but they need education, or they want to, you know, they want to talk about their lab results or whatever. So that's really beneficial to the doctor and the patient. The other things they get are cheap medicines. Literally a Z-Pack for a cold. It's $20 at our local pharmacy. I give it to them for $2. $2. That's really, really saving a lot of money. We save so many people on medications. So the initial investment, I put $3,000 worth of medicines in right at the beginning. I had to have something to start on. We can usually get medicines overnight. I have to buy $100 at a time to save on shipping. So I usually order that about once a week, maybe 200, you know, some weeks, depending on who's coming in and what's needed. We have lost some of the medicines. They expired. You know, that's just part of the, you know, that just happens. So you kind of get used to which medicines to keep, how much to order. At first we may have ordered too much of a few things. You know, we took a loss on that. The other thing you offer them is everything in the clinic that I do is at no cost. So if they get an EKG, doesn't cost them anything. In my other clinic, it's 25 bucks. You know, you get reimbursed. Or cash patient pays $25. They don't pay anything. If they get injections, Rocephin shots, you know, we only get reimbursed a little bit on those anyway, and they don't cost a lot. Steroid shots, you know, in any of the, if I suture somebody, so this is something that, I have a patient who has kidney, she's on dialysis, 84 years old, called me on Thanksgiving. I live right down the road. I'm 4 or 5 miles from my clinic. She cut her head open, needed stitches, gonna have to go to the ER. I'm like, don't go to the, and she's my DPC patient. She also has health insurance. She's 80, you know, she's got Medicare, the whole bit. I said, come to my clinic, I'll sew you up. She was thrilled, so happy. And I didn't have to do that. But she's supporting my clinic, even though she doesn't need to. I love that woman. She loves me. I'm gonna sew her up. I went and sewed her up, and she was so happy. And that was thrilling. It didn't cost her a penny, you know. And I did have to go on Thanksgiving night. You know, I was with my kids. I think my kids were there. They didn't care. It took me 45 minutes and it was done. I was back. It's just so nice to be able to do that. And if I hadn't had my DP, I still would have done that probably in my family medicine clinic. I would have billed her for it. You know, I would have gotten paid for it. But, you know, so I have a lot of folks that are really like what we do. And so that's just, it feels good. It feels really good. So that's a benefit to the doctor. Labs, we get really cheap labs for them. We do send them out, but they pay for them that day. We have no billing, and that's the reason you can do this. And that's what a lot of doctors, our billing alone in our other clinic is anywhere from $4,000 to $8,000 a month. And it's typically $80,000 to $100,000 a year just for billing before the first employee. That's just before the first employee. That's to scrub them and to do it, you know, to get them sent off to Blue Cross and to send all these places. They send them back to us if they aren't right. Man, this is nothing. They come in, there's no billing. And we even tell them, we do not bill you. If you stop paying, you're done. You know, we do take care of you for the first 30 days if you need something, but you don't pay, you know, you don't get care. And I can't do it. We don't bill. And they'll come in. We had a guy who came in today. He owed us $450 because he hasn't paid since like last summer. He brought $450 to us today. Paid up, and we're taking care of him again. You know. So, I mean, you know, it's like, it's amazing. Because for them to go to somebody else, it's so much more expensive. And we give him his medicines really inexpensively. We have Hispanic folks, we have a lot of folks who don't have health insurance, and it's just really beneficial. It also affords me the ability, we do our classes, like you and I just went for an hour. I couldn't do that 3 times a week like I'm doing now. I am teaching people how to get off their diabetes medicines. You saw that one patient sitting, that lost all that weight, sitting there, and she's smaller than her daughter now, the whole bit. She's off of insulin. Her A1C was 15 last summer, 12 last December. She put herself on the keto diet, started my class in February after she started because she wasn't quite sure how to do it. She was already losing weight. She's lost 50 pounds, 45 pounds. No insulin. And now her A1C is 8.5, and it's going to come on down because, next time we do it, it'll probably be 6. And, it's just incredible to be able to do that. Incredible.
A list of people that you would recommend to the DPC, not your first year, just out of residency, not those guys, probably not.
No, they're doing it.
Oh, are they? Okay.
They are.
Just no debt.
No debt. Tell them to get out of debt. So we got our first DPC, really truly DPC physician in the state is in Fort Payne. I was so excited when I heard he was coming straight out of residency. We got another one now in Birmingham, straight out of residency. And that's actually really a good time to do it because they have no debt. Or if they have school debt, they may have school debt. you know. But I took a scholarship from the state of Alabama. It didn't matter where I went. I had no debt. You know, it did matter. I mean, I had to go to a rural area, but it didn't matter how I practiced. I could still do DPC, and they pay for my education because they need rural doctors. So you can get out of debt. There's ways to do it if you go to a rural area, and you only have to be there 4 years. So even if you were having kids, you have your babies, you may not want to go to school there, you can move, you can go somewhere else.
So I could have graduated from medical school last year and get the state to pay for my
all of
debt.
your, all your medical education.
I just did a rural
practice. Yep. So it even, you know, you can come right out of residency. In fact, a lot of they're trying to encourage doctors to do that right out of residency because they don't have to worry as much about debt. They don't have so much tied to, you know, their practice and their location and all that. Some people ask a lot about Medicare. There's a lot of doctors opting out of Medicare. They recommend it, but they're actually, I did not. You know, there is a chance they could come back and say, you know, your contract says you cannot give this type of thing to our Medicare patients. I only have a handful that are Medicare in my clinic, but they are now looking at DPC, and I just saw an article today, I think this morning, on one of my emails. They're looking at this option to offer Medicare patients. So I didn't opt out of Medicare. You know, that's, like I said, it's usually recommended so you're not attached to anybody in any way, but I didn't because I had my other clinic. Right. So I did the hybrid. So, you know, that may be some consideration that somebody else would want to do, not be in Medicare. I'm trying to think. You know, in the beginning when you don't have any money, you do everything yourself until you can hire somebody. Or you have some money put away, you know, but a lot of people just do everything themselves. So that's something you want to consider. You may have to draw blood yourself. You know, you may have to learn how to draw blood yourself. I only did 10 sticks before I started my practice, and I do not draw blood. I could learn, you know, but I don't. I don't have to. I got a whole team that does it for me. So there are some of those types of considerations. You got to do some things for yourself that you may not, you know how to do, but you can teach yourself. I mean, I've learned how to give shots, you know, and all that. I do all that myself now, although I do still have my team. But, you know, it doesn't change anything we do in medicine in the way, you know, we still give medications, we still take care of people, we still, you know, we do EKGs, we do medicine the same way, it's just a different business model. It has nothing to do with the practice of medicine, it's a business model. And it's just great. It just feels so good. So, business-wise, it's just a good move.
Unless, what are the two reasons why you wouldn't?
Well, there was a guy in Arkansas in a really, really rural area, and he couldn't do it. He ended up having to close. He didn't have enough patients. Because some people, if you're in a really, really poor area and people just don't have any money, $50 a month, there's enough population here, I didn't have that problem. Even though my town is 900, there's a lot of small communities around, the county's not that small. He was in a very, very sparsely populated, you know, you may not be able to do this in the middle of Montana, you know, where there's just not enough people. So it definitely, location can matter, you know. Another, you know, that's the main thing. There are some folks that have had trouble, I think, in some regions, even in downtown Atlanta. They were African American, and they were like they were only seeing 50 to 100 patients, and that's it. And they'd been like that for weeks and months. That's really hard.
So 200 bottom, 600 top, but probably in the middle.
200. You usually break even, and that's a good thing I need to bring up. You break even on money around 125 to 150 people, depending on your expenses. So I broke even sooner. Whoops, I hit it. I broke even sooner because my expenses were so low. So I think I broke even and started making money myself in the clinic at 80.
Okay, wow.
You know, because my expenses were so low. The other thing I did was I shared my employee back and forth between the two clinics for a while. Now, in fact, after 15 months, now 16 months, she just became my full-time employee this month in May in the DPC clinic. So, and I did show a profit last year, but it's because I just left the money in the account. So we just moved a whole bunch of money to make up for my pay. So I'm not taking pay, so I'm taking some pay now out of the DPC clinic, but I'm still paid out of the other clinic. So, and that's 15 months. I wouldn't have had much pay. I'd had a little bit, I'd had some pay, but I wouldn't have had a lot. So, you know, so it's about 15 months, maybe 18, and you don't fill up. It depends on your area. I'll fill up probably to 400 in another year, and that's great. You know, that's fine. A year, maybe a little more. If I don't, I'm okay with that too. You know, I got plenty of income, but so it can take a while to get to your full income. You just got to be ready for that. And some places go a little slower, and some places are full. Locally, we had down in Anniston, which is about an hour and 15 minutes from here, they had 350 patients off the bat, like within 6 months. That's really good. I did not have that here.
They needed a doctor.
Yes. Well, it was just the other thing they had going for them was they had businesses get involved, because you can really save businesses money. We don't, you know, we've been working with businesses here, but we really haven't gotten anybody on board to try to save, because of healthcare costs in their business, to get, you know, we don't have a lot of the HSA accounts, those health savings accounts. We don't have a lot of that out here. So we really haven't been able to get a business on board yet. And when you do that, you know, you're doing really well, because you get lots of employees all at once. And that's kind of what they did in Anniston. So she had, you know, like I said, she had about 350 patients within 6 months. I was like, wow. So she'll be full in a year and a half. But that, you know, that may go on some places, but it may not go on other places. You just kind of have to be prepared. And you may not know, you know, it may be hard to know. But if you've got an established practice, you take about 5 or 10% of the patients you already have. And that's about what I've done. And then I got all these new ones. So.
And then once they come in, what's your best guess of attrition for your patients?
Yeah, that was another thing I'd asked when I was trying to get in it. We do have some every month. We probably lose 3 to 5.
Every month?
But we gain about 10 to 15
so
every
you don't
month.
Really lose any.
No. Yeah. So, and actually we look at it about every 3 months. Angelina may go through it. She may not go through the whole list every month, but every 3 months we always go through the whole list. And if somebody hadn't paid, we call them up. We say, "Do you want to do this?" You know, or we just archive them. Right. If they come back, now if it's been a while, like this guy today, he paid all his fees back. We've never really had anybody come back after that amount of time. He's the only guy, and we asked him to pay. We're like, this isn't fair. You got to pay. Because we'd already actually gave him medicine in January, and he hadn't paid. So he paid. He came and he brought us the money, and he paid. So, but if they're 1 or 2 months late, we've had that several times. They pay up or they don't come back.
What do you tell them? What do you tell them when you fill up, when you hit your 400? I'm sorry.
Yep. But there's always a little bit of attrition, so we can put them on a waiting list and say, you know, when we drop down, we'll take you.